Paroxysmal supraventricular tachycardia (PSVT). Generally, the term supraventricular tachycardia (SVT) describes to any tachyarrhythmia that arising from above the level of the bundle of His, which is typically cause a narrow complex tachycardia. Means the duration of QRS complexes is less than 0.12 seconds, or less than 3 small squares. There are so many types of supraventricular tachycardia, and they may be regular or irregular supraventricular tachyarrhythmias. But in this video, we will focus on the electrocardiographic features of paroxysmal SVT and their possible managements. So what are the classic EKG findings of PSVT? These are the ECG features of paroxysmal SVT. Narrow QRS complexes less than 0.12 seconds. Regular RR interval. Rate usually between 140 to 290 beats per minute. Usually the P wave is absent or not identifiable, and buried within the QRS complexes, or may be visible retrograde. May seen also ST segment depression. SVT may also cause a broad complex tachycardia if the patient also have a bundle branch block. So let's check this example. The QRS is narrow as shown here, and regular ventricular rhythm. The distance between RR interval is regular. Rate here is somewhere 215 beats per minute, with the normal axis. No P wave at all, and there are ST segment depression. Management of stable patient. First of all, the patient should be on continuous ECG monitoring, so that we can monitor any changes during non-invasive procedures or IV medications. So the first thing we will try in stable patient with a paroxysmal SVT is a Valsalva maneuver. This can be done by asking the patient to blow hard against resistance. For example, blowing into a plastic syringe or bear down, followed by supine position, and leg raise for 15 seconds. We may also perform carotid sinus massage. This is another procedure done if Valsalva maneuver didn't help. If these procedures don't work, the next step is adenosine. Adenosine slows down or blocks the activity of the atrioventricular node for short time and resets back to normal sinus rhythm. The half-life of adenosine is less than 10 seconds, and it should be given as a rapid IV push so that it reaches the heart quickly. It often causes a brief period of asystole. The initial dose recommended is 6 mg rapid IV push. The adenosine is injected rapidly, followed immediately by the 20 ml bolus of normal saline in the same port. Then the patient's IV arm should be raised above the level of the patient heart to speed drug circulation. After administration of adenosine, watch a cardiac monitor and note that the patient's rhythm slows. There is a brief period of asystole, and the patient may complain shortness of breath, chest discomfort, and flushing. This may be scary for a patient and the clinician, but there is no need to treat. Simply observe. If still didn't work, we will double the dose. We will give 12 mg, utilizing the same technique. So we give first 6 mg, then 12 mg, then 12 mg. If adenosine is contraindicated or didn't work, alternatively to adenosine is calcium channel blockers, like verapamil and diltiazem. Unstable patient. Unstable patients with SVT are always treated with synchronized cardioversion.